Welcome to the Cholesterol Wars, Navigating a Shifting Battlefield, a joint continuing medical education program brought to you by the North American Thrombosis Forum and Ciencia CME. Statin therapy is the recommended treatment for lowering low-density lipoprotein cholesterol, LDL-C, and reducing atherosclerotic cardiovascular disease, ASCVD risk. However, evidence-based and guideline-recommended therapies, including ezetimibe and PCSK9 inhibitors, continue to be underutilized, even among the highest-risk patients. Consequently, an unmitigated burden of cardiovascular risk persists. More education is urgently needed to address this problem. To that end, we invite you to join us for this series of webinars to discuss some of these key issues in cholesterol management. You are watching Part 3, Recent Cholesterol Guidelines and Integration into Clinical Practice. This program is designed for physicians, pharmacists, nurse practitioners, physician assistants, nurses, and allied healthcare professionals in the fields of internal medicine, primary care, family medicine, hospital medicine, cardiology, and endocrinology. The learning objectives for this module are listed here.
Welcome to this North American Thrombosis Forum CME's webinar series, The Cholesterol Wars, Navigating a Shifting Battlefield. It's an exciting title for an exciting topic. I'm Jorge Plutsky. I'm the Director of Preventive Cardiology at the Brigham and Women's Hospital. And in today's session, we're going to be discussing about how to integrate cholesterol guidelines into practice. We have two great speakers, as I'll introduce to you. The North American Thrombosis Forum, NATF, is a nonprofit organization dedicated to improving the lives of those affected by blood clots and related diseases. They use comprehensive resources and innovative programming. And through those, NATF strives to educate patients and healthcare providers about thrombosis and its complications. I've been fortunate to be involved with them on a variety of programs, and they really are terrific and do a great job. And so to the extent that this is your first interaction with them, I encourage you to seek them out, look at their website, because it's really very high quality content, as we're going to see today, and a real resource, I think, for all of us. This is a program supported by an educational grant from Amgen. These are the disclosures of financial relationships, and mine in particular. As a moderator, you'll see these here. I'd like to briefly address the notion of that might give you pause of why a thrombosis foundation and forum is engaging around cholesterol lowering. And really, I think it highlights the extent to which we now recognize the interconnections between these disease states and also the management of them, and how often patients present with overlapping issues as related to atherosclerosis, thrombosis, and the impact of hypercholesterolemia and the therapies for hypercholesterolemia on those issues. And so, sitting across from a patient, they don't present in compartments. They present with these issues often overlapping. And to have a trusted resource like NATF willing to take this on and to bring together all the disparate aspects of our community of providers and patients is really terrific. So I think it makes perfect sense to me, and I'm just excited to take part and to be able to call upon colleagues to discuss these issues. And I think today we are going to have some very unique perspectives about this. I'm going to introduce our first speaker today. It's Dr. Lynn Braun. Dr. Braun is a nurse practitioner, professor emerita in the Department of Adult Health and Gerontological Nursing at the Rush University College of Nursing. She's also a consultant in the Rush Heart Center for Women. Dr. Braun is an authority in this area. She's the co-author of 5 AHA-ACC scientific statements and 3 AHA clinical practice guidelines, including the 2018 Multi-Society Guidelines on Management of Blood Cholesterol. She's a diplomat of the Accreditation Council of Clinical Lipidology, and really is just very well positioned to integrate and explain these issues and outline them for us. So, Lynn, very appreciative of your being here and looking forward to your presentation.
I really appreciate the invitation to speak at this webinar. So I'm going to move along. We're going to talk about the AHA-ACC cholesterol guideline today. I have no financial relationships to disclose. So our objectives are to review the guidelines used in US-based practice. So most of my presentation will be on the AHA-ACC Multi-Society Guideline, but I will mention the United States Preventive Services update that just came out earlier this year. Secondly, we're going to assess guideline-recommended strategies for lowering LDL cholesterol in both secondary and then primary prevention, and develop evidence-based treatment plans based on recommendations from the cholesterol guidelines. Joyce Ross has a very interesting case study that we will apply these guidelines to. The very first recommendation in the cholesterol guideline is on lifestyle counseling, which is critical. Lifestyle, as we know, is the foundation for atherosclerotic cardiovascular disease risk reduction. Very, very important. We know that in young individuals, lifestyle will help to prevent the development of risk factors in the first place. And whether or not we, as clinicians, intend to recommend drug therapy, it is equally as important to counsel on lifestyle. I borrowed a couple slides here from the 2019, 1 year after the cholesterol guideline, the primary prevention guideline, because it addresses lifestyle. So the nutrition component is that we should counsel on the emphasis of vegetables, fruits, legumes, nuts, whole grains, and fish, replace saturated fats with dietary mono and unsaturated and polyunsaturated fats, and to reduce the amount of cholesterol, sodium, and of course, sugar in our diets. The exercise component states that adults should be routinely counseled in healthcare visits to optimize a physically active lifestyle. And the specific recommendation is the same as the federal recommendations for physical activity and exercise. So to accumulate at least 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity aerobic physical activity or some combination thereof. But equally important, especially with some of the patients that we take care of, if an adult is unable to meet those minimum physical activity recommendations, it's very important to state that anything is better than nothing. So anything you do above your baseline can be beneficial to reduce your cardiovascular disease risk. And sedentary behavior should really be decreased. Even among avid exercisers, we know that sitting for long periods of time is detrimental. It increases mortality, increases cardiovascular disease risk. So I tell my patients to move every 5 minutes at least. The secondary prevention recommendations are here. So in patients with known clinical ASCVD, reduce LDL cholesterol with high-intensity statin therapy or maximally tolerated statin therapy. Of course, we know now that lower is better. So the more LDL is reduced on statin therapy, the greater will be the subsequent risk reduction. Very, very important. And In order to do that, the guideline directs us to use a maximally tolerated statin to lower LDL levels by 50% or greater. This is the table from the guideline that divides statins into intensity. So a high intensity statin, which reduces LDL to 50% or greater, would be either atorvastatin 40 or 80 milligrams or rosuvastatin 20 or 40 milligrams. The guideline addresses high-risk individuals and then very high-risk individuals. So pertinent to the very high-risk individuals, those at very high risk for ASCVD, we're instructed to use an LDL threshold of 70 milligrams per deciliter, at which to consider the addition of non-statins to statin therapy. So what does very high risk mean? Very high risk includes a history of multiple major events, ASCVD events, or a major event plus multiple high risk conditions. And the next slide I have addresses those high risk conditions. But if someone is at the threshold of 70 milligrams per deciliter or greater on maximally tolerated statin therapy, it is reasonable to add ezetimibe. And if the LDL continues to remain at 70 or greater on maximally tolerated statin therapy plus ezetimibe, it's reasonable to add a PCSK9 inhibitor. These are the high-risk conditions that the guideline mentions. So older age, heterozygous FH, history of bypass surgery or percutaneous intervention outside of the major ASCVD event, history of diabetes, hypertension, chronic kidney disease, current smoker, very, very high risk, persistently elevated LDL, or a history of congestive heart failure. This recommendation pertains to severe hypercholesterolemia, which, as we know, is very high risk. And I put FH after the title here because for most individuals having an LDL cholesterol level of 190 or greater, they are found to have familial hypercholesterolemia. So if the LDL is 190 or greater, do not calculate their risk score, begin high-intensity statin therapy right away. And there are a couple qualifiers here then. If the LDL remains at 100 milligrams per deciliter or greater, it's reasonable to add ezetimibe. And if the LDL level on statin plus ezetimibe remains 100 or greater, and especially if the patient has multiple risk factors or multiple factors that increase their risk, a PCSK9 inhibitor may be considered. So ezetimibe and a PCSK9 inhibitor are also recommended for familial hypercholesterolemia or severe hypercholesterolemia if the patient is already on maximally tolerated statin therapy, and that is not lowering LDL cholesterol enough. So according to the AHA-ACC guideline, we have 3 agents to use in secondary prevention that lower cholesterol and lower ASCVD risk. We have good outcome data with all of these 3 agents: statins, ezetimibe, PCSK9 inhibitors. They lower LDL cholesterol through different mechanisms and complement one another. Since the publication of these guidelines, we have other agents available to us, and I will mention those toward the end. The recommendations for diabetes are that in patients 40 to 75 years of age with diabetes, and an LDL of 70 or greater, start a moderate intensity statin without calculating 10-year risk. We know that people with diabetes have an elevated risk for ASCVD. So this recommendation to automatically start moderate intensity statin therapy is in fact consistent with the ADA guidelines as well as the Endocrinology Society guidelines. And then if somebody with diabetes is really at higher risk, they're at an older age, they have multiple risk factors, the recommendation is to jump to a high intensity statin to reduce their LDL by 50% or greater. Okay, moving into primary ASCVD prevention now. When we talk about primary prevention, what jumps out in the guideline is the fact that it's imperative to have a clinician-patient risk discussion and to engage that patient in shared decision-making before starting a statin. So with primary ASCVD prevention, there's a little bit more wiggle room. So that risk discussion should include a lot. It should review the patient's major risk factors. It should estimate their 10-year risk for an ASCVD event. It should address whether or not they have any risk-enhancing factors that are not part of the risk estimation. It should address the potential benefits of both lifestyle and statin therapies, the potential for adverse effects and drug-drug interactions. It should consider cost of statin therapy, and it should acknowledge the patient preferences and values and incorporate those in shared decision-making. So this is the ASCVD risk estimator that we're all used to using, of course. And again, this is based on the pooled cohort equations. I'll say a word about those in a moment. But I think it's important to think through how we communicate this information to our patients. And just to give an example, what I say to my patients, this happens to be a 55-year-old African-American female with elevated blood pressure and elevated cholesterol. And she has close to a 16% 10-year ASCVD risk. I would say to her, if there were 100 people just like you, same sex, same age, same race, with the same risk factors, we can estimate that 16 of them in the next 10 years would go on to have a heart attack or a stroke or die from cardiovascular disease. So I try and talk about the numbers in that way to drive home the point that she, in fact, is at elevated risk. The pooled cohort equations are, right now the best that we have. They include a broad utilization. They are the most widely validated score using contemporary United States populations, in fact, 5 populations. More than 23 manuscripts have evaluated them in diverse populations. They tend to be well calibrated near decision thresholds, such as the recommendation that if a person's risk, 10-year risk, is 7.5% or greater, statin therapy is recommended. But as with all risk scores, these equations can under and overestimate true risk in some subgroups. So it's important to know that these risk estimations start the risk discussion. They're not the end all and be all point. If somebody's at 7.5% and a statin is recommended, that starts the discussion, but we've got to talk about much more, as I mentioned a couple slides ago. So what about the performance of the pooled cohort equations? There's reasonable calculation overall. However, they've been shown to overestimate risk in the healthy populations and people with a high socioeconomic status, patients who are very engaged in lifestyle and their care. But they underestimate risk in other populations, such as individuals with low socioeconomic status, people with HIV disease or inflammatory disease, or people who have an ethnicity that's considered to be very high risk, such as South Asian. That's the purpose of the risk discussion then. The primary recommendation for the major recommendation for primary prevention then is that in adults without diabetes and a 10-year risk score of 7.5%, start a moderate intensity statin if a discussion of treatment options favors statin therapy. If it favors statin therapy. And it goes on to say, if the person has risk-enhancing factors, and again, these are factors that are not part of the risk estimation, then this would especially favor initiation of statin therapy with a 10-year risk score of 7.5% or greater. These are the risk-enhancing factors. And by the way, the relative risks associated with these factors are in the supplement to the guideline. So the relative risk associated with these factors and coronary heart disease risk. So what are they? Family history of premature disease, persistently elevated LDL, having metabolic syndrome, chronic kidney disease, a couple women-specific factors, history of preeclampsia or premature menopause, the presence of chronic inflammatory disorders, being of a high-risk ethnic group such as South Asian, and having persistently elevated triglycerides. Some other measurements, some biochemical measurements would be an elevated ApoB if it was measured, and it says if measured, it doesn't say measure these. High sensitivity C-reactive protein, an ABI less than 0.9, and a lipoprotein A that is elevated. And we know that our guideline says if measured. This contrasts a bit to the European guideline, cholesterol guidelines, which state that that lipoprotein A should be measured at least once in a person's lifetime. What came out unique in these guidelines is that if there is not a decision about statin therapy that is certain, so if the decision about statin therapy remains uncertain, despite the conversation with the clinician and the patient, and the person is at intermediate risk, having a 10-year risk estimation of 7.5% to 19.9%, to consider the measurement of coronary artery calcium to help with that decision. We know that if there is any coronary artery calcium present, there's atherosclerosis, there is disease. So if that test is done and the score is 0, unless the individual has certain high-risk conditions like diabetes, cigarette smoking, etc., it may be reasonable to withhold statin therapy and reassess 5 to 10 years later. But if the score is 1 to 99 and less than the 75th percentile for the age, sex, race group, it's reasonable to initiate statin therapy, especially for people 55 years of age or older. And then there's that cut point of 100 here. If the score is 100 or higher, or a person is in the 75th percentile or higher, it's reasonable to initiate statin therapy. So sometimes this will help a patient feel more comfortable about starting statin therapy if they know that they already have the presence or the start of atherosclerotic cardiovascular disease. So for those that are not used to looking at coronary artery calcium scans, those bright spots indicate the presence of calcium. This is a kind of an algorithm that was designed by Dr. Don Lloyd-Jones, and he refers to this as CPR. So for primary prevention, we start by estimating the absolute 10-year ASCVD risk. So the C stands for calculate. The C stands for calculate, and the patient is put into a bucket of low, borderline, intermediate, or high risk. Secondly, there's a clinician-patient discussion, and risk-enhancing factors are also considered that are not part of the risk estimation. And then the net benefit of therapy is discussed, and the patient's values and thoughts enter into the conversation. So that's the P for personalize risk. And yet, if there's still uncertainty or the patient indecision remains, consider ordering a coronary artery calcium score and revise that decision based on the results. Here we go, reclassify potentially. If the score is 0, the advice at that point may be lifestyle modification. But if there is coronary artery calcium, the advice would be lifestyle and drug therapy. I just want to make mention of primary prevention in older adults. In adults 75 years of age or older with an LDL level of 70 to 189, the guideline does state to initiate a moderate intensity statin, which may be reasonable. Since age is a big driver of the 10-year risk, someone of this age is almost automatically going to be at the level where statin therapy might be recommended. But once again, there needs to be a clinician-patient risk discussion. And then I like this other recommendation. In adults 75 years of age or older, it may be reasonable to stop statin therapy when functional decline, whether it's physical or cognitive, multimorbidity, frailty, or reduced life expectancy limits the potential benefits of statin therapy. We know that risk for ASCVD does increase with age, and yet most of the randomized clinical trials, most of them included moderate intensity statin therapy and have shown a significant reduction in major vascular events, even among older individuals who are greater than 75 years of age. It's important that we assess adherence and LDL reduction. One of the latter recommendations is to assess adherence and % response to LDL lowering medications and lifestyle changes by repeating the lipid measurement 4 to 12 weeks after statin initiation or dose adjustment, and then repeating every 3 to 12 months as needed. You know, when you start a person on a moderate intensity statin, for example, you should expect to see about a 30 to 49% reduction in LDL cholesterol. So compare that with what you're actually seeing. And perhaps in our discussion, maybe we can talk about ways to actually assess adherence. There's some additional guideline content that I didn't have time to really talk about, and I listed that guideline content on this slide. I just wanted to mention the recommendations from the recent U.S. Preventive Services Task Force on statin use for the primary prevention of cardiovascular disease. This was an update to the 2016 recommendation. It basically states that in 40 to 70-year-old adults with one or more cardiovascular risk factor and an estimated 10-year cardiovascular disease risk of greater than 10%, this would be the time point to initiate a statin. If the risk is slightly less, 7.5 to less than 10%, selectively offer a statin. It's a lower grade that they gave it. And for older adults, they state that evidence is insufficient to recommend for or against starting a statin. One more mention of something that's come out more recently is the ACC expert consensus decision pathway on the use of non-statin therapy for LDL lowering and the management of ASCVD risk. Because since the publication of the cholesterol guideline, we have other agents available. Bempedoic acid, evinacumab, which is specific for homozygous FH, and then inclisiran. We are still awaiting cardiovascular outcome trials for all of these agents, and at that point there will probably be a revision of the evidence-based guidelines. But the ACC in this document has provided several algorithms based on specific case situations in which to employ the use of these newer agents. So take a look at that document. Guideline implementation is really important. We can have all the guidelines in the world, but unless we share the information and implement the guidelines, we're not going to reap the benefit of the purpose of those guidelines. So we need multifaceted strategies, effective clinician dissemination strategies, multimodal education, the application of the education strategies to all clinicians, not just physicians, and perhaps consider the involvement of patients and consumers. Adherence is very, very important. That clinician-patient discussion is critical because it involves the patient. It engages the patient. So the patient will be more likely to adhere. We can help them with different interventions to foster adherence, like phone or watch reminders, etc. It's important to identify patients not receiving guideline-directed medical therapies in our health systems and our practices. So every health system or practice should have a plan for doing so and to leverage the EHR for this purpose. We need to standardize processes and procedures, and we need effective communication among all clinicians. Finally, my key points are that the 2018 AHA-ACC Multi-Society Cholesterol Guideline is comprehensive but user-friendly. It allows for an aggressive approach to the patient with ASCVD and a more tailored approach to primary prevention of ASCVD. The United States Public Services Task Force guideline has updated the evidence for primary prevention, but once again, they presented a more conservative approach. They do not incorporate risk-enhancing factors or the CAC score. All clinicians play an important role in cholesterol management. You know, I'm a nurse, so I specifically wanted to include the fact that nurses respond to questions after a prescription is given. We clarify information, we address adverse effects. We're the first line of communication with the patient. We communicate with our pharmacy colleagues, and pharmacists communicate directly with patients. All clinicians are well positioned to conduct educational and QI projects that facilitate guideline implementation. And in essence, it takes a team approach to ensure guideline adherence.
Lynn, thank you. That was a terrific integrated overview of these issues and touched on so many important aspects of them. So I'm looking forward to discussing them further and seeing the ways in which they can be applied, given the nice connection between your talk and what we're about to hear from Joyce Ross on recent cholesterol guidelines and integration into clinical practice, a case study. Joyce Ross is a certified registered nurse practitioner with concentrated training in preventive cardiology. Joyce has received accreditation as a clinical lipid specialist by the Accreditation Council for Clinical Lipidology. She's clinically affiliated with the University of Pennsylvania, and just like Lynn, is very experienced and just the right kind of person to help us put this into clinical practice through a case study. And I know she has made huge efforts to join us today despite some challenges. So Joyce, thank you for being here, and we're looking forward to your presentation.
Thank you very much. And I'm really grateful for the opportunity to take the work that Lynn has just presented to you, which is always excellent, and then put it into practical terms. And I'm going to take one little piece that she gave you about that calculation again and use that to say, sometimes we forget to calculate when changes are made in our guidelines to really reclassify our patients. So I really want to make sure we emphasize that changes need to be done in treatment plans because the guidelines change. These are my disclosures. And the learning objectives determine the appropriate LDL-C level for a patient using information including CAD. Risk-enhancing factors, as Lynn has told you over and over again, are so critical, and updated guidelines and recommendations. Describe the patient-provider conversation as a means to increase appropriate continuance with agreed care plan. Apply evidence-based treatment plan for patients with elevated LDL-C with a history of statin intolerance. And I'm sure you all have been faced with the patient who has statin intolerance, which can lead to a tremendous amount of problem for our patient if we don't have good communication skills. Ellen is a 62-year-old woman who is status post-hospitalization for unstable angina. She has a positive family history for CAD. Until hospitalization, she had never experienced any kind of cardiovascular symptomology. She is a smoker, and as Lynn said, this is one of the most detrimental things that this patient has besides her family history. She drinks alcohol about 6 to 8 beverages per week, and she does not do any physical activity. So really, this is a person whose lifestyle is going to be critically important in our care plan. And we know it's sometimes easier for people to take a pill than to get up and move, as Lynn has said, and also to think about dietary changes. This is a Hispanic woman, and she has a lot of foods that are very rich in fats and that type of thing, and not a whole lot of salad and vegetable use for her. Her past medical history, she's had hypertension treated with an ACE inhibitor, and she tolerates that without any problem, and her blood pressure is generally around 122/68. She has a long history of arthritis in her neck and shoulders from an automobile accident many years ago, although she takes a tremendous amount of ibuprofen for that. One of the considerations here with a large amount of ibuprofen for her, it's going to have an effect on her blood pressure, which she also has. Those concomitant things that Lynn discussed. She's also a COPDer. And of course, she's treated with her normal everyday inhalers, and then she has a rescue inhaler. She claims not to have too much difficulty with this. However, she doesn't challenge herself to do much. So we don't know if she was up walking whether she would have more difficulty. Her past history, she's identified as having high cholesterol at age 52 and had difficulty tolerating statin therapy, failing one high-dose statin and one low-dose statin, and felt to be statin intolerant. And here's where the problem lies. What she heard is, I can't take anything. Okay, I guess I'm doomed. She really didn't think too much about it because she just didn't think it was that important. If she couldn't take a statin, she couldn't take a statin. That's where the breakdown happened for this patient. The provider and that patient should have had a very long discussion then about what else can we do. Maybe a statin is not working for you, but let's work with your lifestyle. And then there are other medications that can be taken. So if she had gotten that discussion, she may have not got to the point where we met her 10 years later. So she fell through those cracks and had no cholesterol treatment for several years. But then she got worried about it, believe it or not, because she kept hearing on television the need to get the LDL cholesterol. So she thought, well, I better see something, better do something. She did look up a lipid specialist that was on the website from the NLA and made an appointment. And this was prior to her hospitalization. And through very creative prescribing to work up to a tolerable statin level of pitavastatin at 2 milligrams, it was tolerable. But what was her target at that time? And she should have been at least less than 100. And but she you'll see as we go through the numbers, she wasn't too far from that with the pitavastatin. But the problem is that she moved away from the area. That's why she was coming in for a new evaluation. Her blood pressure was 122/68, but her BMI is 24, and she's got a lot of weight around her middle, and so she's not in good shape that way. Her total cholesterol 178, triglycerides 128, HDL for her low for a woman at 46. Her LDL is 106 on a maximally tolerated statin, and she did have a high Lp(a), and that tells us that she's inherited some of these qualities. That makes that LDL cholesterol that much more atherogenic. So it gives us call to maybe change the level at what we would use her threshold. And here's the 2018 AHA/AC blood cholesterol guidelines secondary ASCVD prevention chart, which is excellent. And here's where the science and the art of medicine meet each other. Because what happens here, you have to take a look. We know she's a very high-risk patient, and we know that she's had problems with her statin therapy. I know she needs to be lower than where she is now, but how am I going to get there with this patient? And I had to consider a whole lot of things before I could make up my mind whether she needed to go right to a PCSK9 inhibitor, or were we going to take that step of using the ezetimibe? And I think what's important here is that when we know something's not going to work, I don't want to set this patient up for any kind of frustration. Therefore, I'm going to be more inclined to be sure that I'm trying to hit my mark on the first shot. Now, these risk-enhancing factors, I want to show you again. No, Lynn presented them for you, but I wanted to point out this particular patient. She has a family history of premature ASCVD, and I didn't tell you before that her blood sugar levels are running about 102, 103. So she's getting into that problem with possibly heading towards metabolic syndrome. And she does not have it at this particular time. She has no chronic kidney disease, no history of preeclampsia, but she does have chronic inflammatory disorder. She has two, one the COPD and the other her problem with her shoulder. Today, we really think much more about these inflammatory process, since we know that cardiovascular disease is an inflammatory process. Years ago, I don't think we looked at it nearly as much as we should have. Ethnic groups, of course, and persistent elevated triglycerides. And she did have the Lp(a) done, and again, it was greater than the number, and we have to consider that in her overall. So when we think about her, we're going to think lower is better, but what low is the right low for her? It certainly isn't at 100. And in my mind, it's certainly not necessarily at less than 70. Because of the glucose, I'm a little concerned that she's going to end up being a diabetic situation. So what we did, we started talking about what kind of medication is best. So here's where the shared decision-making comes in. One of the most important things for this patient at this point is to establish a trusting relationship between the two of us. Sharing exactly what happens, sharing what the drugs do. And sometimes I think that we don't go into enough depth to have a patient understand why we're giving them something. It's not just to lower a number. When we lower the LDL cholesterol and we're using a statin drug, we're doing a lot of things. We're decreasing inflammation, clot formation, all that type of thing. So I think it's important to talk to her about the statin drug and how important it is for her. And I'm thrilled that she is able to tolerate a statin, but she obviously is not going to get to where we need to go. So we have discussed her major risk factors, and she has several, as I said, and she's heading for many more, and that's the big problem. I want to keep her from going any further into this more serious business area. Establishment of the LDL threshold, role of the lifestyle management, which she certainly needs, need for more intense therapy, such as based on risk factors, potential side effects in medication. This person, you're really going to have to go over the side effects and potential, and use the word potential, because sometimes when we tell somebody something, they look for it to happen. So I like to think to the patient, it's talk about it and tell them how often it happens in most populations, but I'll be right there if there is any issue and we can ameliorate any problem or go to another course. We have to talk about how much this costs. This woman doesn't have a lot of money, and that we don't want to give her too many medications that are going to cost too much, because she's just not going to get them. So once the plan has been established, we need to verify, asking the patient, what did you hear me say? Important to have that feedback, because I want to know, did she hear all the things I wanted her to hear? Because sometimes we assume it because they don't have a blank look on their face or something. What are their preferences? What do you expect to get? What do you want? What questions do you have right up front for me? And I also should have put in there, what fears do you have? Because she was a lot of intrepidation because of having problems with a statin before. Can they fully participate in the plan that we create? Is there a potential risk for reduction with a good treatment plan? And also talking about drug-to-drug interactions with is very critical for patients. So developing the treatment plan. Our patient qualifies as a very high-risk patient, therefore appropriate to lower the LDL, and I go to 55 on here. I know that's a little more aggressive than the guideline, but that's where the science art of medicine. She illustrated that she wanted to be very aggressive. And with that glucose level right at the edge, the Diabetic Association has said less than 55 is good. So we talked about that, and she wanted to be more aggressive. She was worried that she waited too long and has caused herself a lot of problems. So how much LDL lowering is required to get to that less than 55 milligrams per deciliter? Could I try to increase the statin therapy again? No way. I'm not going to go to that, because she's comfortable now with the statin she's taking, and I could get lowering, but I don't put her through that. Add the ezetimibe as indicated as the next step, but she's only going to get about an 18 to 20% LDL reduction, and she needs 50% reduction. And so therefore, I've got to be very careful that I give her enough of the medication to take care of her. And so I also wanted to talk about adding icosapent to ethyl as a way of furthering risk as well. It has no effect on LDL cholesterol, but it may be something that's very important to add on to her, because we see from the REDUCE trial, we noticed that what we did, we had a overall 20-25% reduction in the next cardiovascular event when this was applied to the regular therapy. But that was too soon. Now, Lynn, here's where I'm going to go and say, we need to get our good friend to even think about revamping this for the secondary prevention, because I'm afraid so many people do not get reassessed when we have these new things. So we don't have to estimate the 10-year. We know that because we talked about that. But that client-patient discussion consideration, critically important here. And what was the net part? So we calculate again and personalize. And then what we have to do is we have to reclassify her because she wasn't classified in the appropriate way. And unfortunately for women, we tend to have a lot more problems as, getting these things done. It's not that people ignore women. It's just that, we don't treat them aggressively enough. You all know about PCSK9 inhibitors, and we know what they do. But I'm going to give you my simple thing for PCSK9 inhibitors. And what they are is save the receptors. The receptors that are found on the liver are responsible for getting the cholesterol into the liver and getting rid of it in the end of the day. Well, our FH patients, as Lynn pointed out, have a problem. They don't have enough receptors, or their receptors don't work well. But even people like my patient here, they also have a lot of reasons why they might not have good ability to get their receptors to work. When you take something like a PCSK9 inhibitor, what you're doing is you're essentially keeping the receptor from being broken down. When you break down the receptor, you're going to have high LDL cholesterol. If you block the degradation of the LDL receptor, then you have very much lower LDL. So for patients, it's a very difficult thing to explain to them, but it's critical to really go through that whole thing about what am I doing? I'm blocking something that I need to get rid of the cholesterol. So important there. And I really like to point this out too, because in this patient, I'm really anxious to get her to a very good level because she's been a long time not being aggressive enough. And this is from the Odyssey long-term trial with alirocumab. And you can see at 4 weeks time of dramatic lowering of the LDL cholesterol. And what you have is consistency over a long period of time. So she's not going to have the bouncing up and down of the cholesterol, and she will be able to meet her goal with this. Well, she had some concerns about this because she heard that it can make you crazy if you take these, if your LDL is too low. But introducing the work from the Ebbinghaus trial, you can say that there was concern over very low levels of LDL with PCSK inhibitor in therapy. In subgroups of patients from Fourier, prospectively assessed cognitive function using the Cambridge Neuropsychological Test Automated Battery. In over 1,200 patients, they were looking over 19 months. And at the end, they found no differences cognitively in the patients treating with a low level of LDL because of a PCSK9 inhibitor. Very, very important information to talk about. So the treatment plan, you're going to see, this is what you saw Lynn talk about. And of course, that exercise is critical for her. And she really jumped into that. I was really surprised. She really jumped into that. Stopping smoking, not so much. Her thing is, I'm not ready to do that. I'm willing to try in the future, but I'm not ready to do all these changes at one time. That comes accepting the patient on their level. Because if you're not accepting them where they are, you're going to break down that trust and that relationship. Certainly going to be encouraging, but not forceful. The alcohol use, I asked her to cut down to less than 1 drink a day because that was above what she should have. And her triglycerides are greater than 100, so that would be useful there as well. Next steps, we added the PCSK9 inhibitor. She tolerated the new therapy without any problem. Still needs to work on the smoking, but she is walking 3 to 4 times a week for 10 to 15 minutes. And nicely, she's not having difficulty with her COPD with that. Now, who knows what happens when it gets cold or something like that. Reducing the alcohol to once a day, she did that. And after 4 weeks, we got new blood work to see the efficacy and safety of what we had done. Her total cholesterol was 112. Her triglycerides were 100. Her HDL still low at 42. Her LDL was at 50. Is that too low? And that's where that discussion comes again. And that's what's important to say to the patient. We know the trial that says it doesn't affect your cognitive function with being low. Clinical pearls. Become familiar with the guidelines. And Lynn, you do a beautiful job of describing them, and your patient deserves that same kind of discussion from you. Guidelines are based on specific primary and secondary treatment algorithms, along with risk-enhancing factors to help establish threshold goals. Statin therapy remains the gold standard. Remember, we always want that statin on board when we can. Guidelines are designed to provide providers with options for treatment when statins are insufficient to treat thresholds. Remember, guidelines are guidelines. They give us a map. And then our medical management comes in from our use of practice and also just good medical judgment. Prior to starting a treatment, a patient-provider conversation is essential. Aggressive lipid management has been shown to reduce cardiovascular risk as well as system management with non-communicable diseases. And that's what you mentioned in the very beginning when we talked about it affects things like diabetes, it affects things like thyroid disease, and affects the bloods. So we have to understand that the cholesterol is really affected when you have a lot of diseases. So we have to look at it for these non-communicable diseases in our patients. Thank you very much.
Thanks, Joyce. That was terrific. And so appreciate the content from both Lynn and yourself. And so we have a few minutes here. We have some questions that come in through various sources. And let's go quickly because this is incredibly important. I think one of the overarching issues we encounter is undertreatment of patients. And both of you have targeted this idea of how to identify the right patients and the tools to get them under control. So we'll go quickly, and I'm going to cherry pick. And you've heard of speed dating. This is speed asking. So the first one from our audience, I want to make sure we're attentive to what questions that people have, is when we use the ASCVD risk calculator, we often, and as well as with some of the other assays and measures we might do, get limitation around age. And so if you're seeing a patient who's under 40 and their LDL is not obvious, greater than 190, how do the guidelines, provide input to us about managing that kind of patient? And also, what are your own strategies in having that conversation with someone who's, under 40 and whose LDL is not greater than 190, but still is not optimal, greater than 130? Lynn?
Yeah, I'll take that. The ASCVD risk calculator for the 10-year risk does start at age 40. So that's important to note. However, there is a lifetime risk incorporated into the estimator as well. So very important. Young individuals who have multiple risk factors may have a 50% lifetime risk. So it's important to tell them that, unless this is under control, unless we start to reduce those risk factors, you have a 1 in 2 chance of having cardiovascular disease or dying from cardiovascular disease during your lifetime. So the short answer is lifetime risk is what needs to be addressed.
Yeah, I think this connects to something that came up from both of you, and that has been highlighted is that guidelines only guide, and obviously there's nothing magic about the number of 190. And there's nothing magic about the number of 40. I'd like to tease our primary care physicians, that hopefully they're not sitting across from a patient and saying things like, gosh, your birthday's next week and you'll turn 40, so I can't treat you now. I have to wait till next week. And so that obviously isn't relevant. Now, Joyce, you had a great success there with the case that you outlined. What about patients who are resistant to even starting therapy? Do you have some strategies and approaches when the patient just doesn't want to go on to drug therapy? Or escalate therapy, which is another thing we encounter, that patients who get started on a low dose of statin, they don't get titrated on, or they don't have a second agent added.
Yeah, I think the important thing is that trust that you have between the patient and the provider. And again, hopefully, when you sit down and have that conversation, you're going to ask them, what is your trepidation about considering medication? What is your biggest fear? A lot of times it'll be, my uncle's cousin had such and such with a statin, and all those type of thing. I try to invest people into telling me what hurts you about it, what bothers you. And we can quickly answer those things usually. And then we take their risk factors and talk about, as Lynn said, what is the likelihood that you're going to have a problem in the next years? I find that there's a lot of even people with known disease, and you need that statin, they're also very resistant. So I think telling them what a statin is going to do, tell them how the mechanism works, not just lowering your number. We're going to change the environment. We're going to change that plaque that is in your vessels that's causing your problems. So I think by time you go through what these medications can do, and you also talk about, yes, some people have difficulty in toleration, but if you do, we will walk through it together and we will find something for you. So my approach is to have a very hands-on And again, Lynn mentioned how can the office help? A lot of times, my patients had my email address, and I encouraged them, if they were worried, to send me an email, and then I could answer a question when they needed it, instead of trying to get back to them at the end of the day with a telephone call or something. But I think that and knowing that they can be in touch with you easily is another way of making sure you get to where you need to go.
Yeah, I've really come to appreciate something that I think all of us in prevention were doing already. But when you realize there's an entire field that studies motivational interviewing,
That's right.
that send me to their literature and what they find to be the case. And one of the things that's really frame shifting, given the fact that we see and know more than our patients can know, is that it can be surprising to us when we encounter resistance. But I really appreciate that one of the central tenets of motivational interviewing is that no one's coming to clinic or seeing us with the intent of harming themselves. No one's saying, I'd like to have a heart attack. I'd like to have a stent. And so there is a barrier for why they're not doing this, whether it's that uncle or something they read online. And that's what we have to address. Lynn, do you think that coronary calcium can be helpful in this regard of trying to make this future notion of prevention, more tangible for patients?
I do. I was responsible for negotiating the price for a cheap price for that at Rush because I wanted to start ordering it. One thing is that, just to be clear, coronary calcium scoring is really only appropriate for the primary prevention patient who is considering or maybe not considering in the long run going on a statin. So it's important. It's an additional piece of information that we may have. And I think it's helpful because it means that if it's present, disease is there. There is the start of the disease. You can pull that up on your computer, show that to the patient to actually say, or they get a hard copy of the report that shows them, where they actually have calcium. So you have to go into some discussion of the pathophysiology of atherosclerosis with your patient. But I think it can be very, very useful. And it can, really guide you as to whether or not lifestyle can be done for the next, for in the short term, if it's with a score of 0.
Right.
I always tell people that it's like a magic ball, and we're just going to look inside your coronary arteries and see what's going on. That has changed many a mind. That seeing that plaque exists, seeing that they have a score, especially in relationship to other people their age. And I found that particularly important in the FH patients because they are young, and the family is saying, "Why do I need a statin?
Yeah.
Why do I need to have these things?" So I think that when you could do the coronary artery scoring, it's very, very helpful for the patients.
Yeah, I think one of the things that I've also started to embrace more, I think it's really important. When we talk to patients, we end up conveying and help educating them and conveying a commitment to it and the importance of it, and so that often influences what they do. I think one of the new adaptations that I'm making more in clinic is to anticipate for patients that we will need to go up on dose and add another agent. And I think we're seeing more of this incorporated into clinical strategies when a patient is not going to get, close to the appropriate number just by adding ezetimibe, of pushing on to PCSK9 inhibitors, that they can be approved. And I want to underscore that for the audience, is not to think that you can't get them approved, but sort of laying that groundwork so that the patient doesn't feel they failed when you say, we're going to increase the statin dose or we're going to add a second agent, that if you mention it up front, that can make that subsequent conversation easier.
Exactly.
And hopefully the outcome studies for bempedoic acid and inclisiran will be positive in the way that we think they are. They will be, so that we can, really present the options to our patients.
Right. And take advantage of all these tools and new insights we have. And so I think you've both done a great job of laying out those resources and strategies for implementation. I really appreciate the content you provided and the insights you provided. I'm sure there'll be more follow-up, and I look forward, Lynn and Joyce, to working with you again and crossing paths. And please keep up the good fight.
Thanks.
We really need you.
Thank you. It's been a pleasure.
Thanks, Jorge. It's been a pleasure.
All right. Thanks to the NATF as well.
Yes.